just flew back from a national meeting yesterday in Ottawa, and Manitoba is actually not going this alone. Everybody's undergoing major change. What I am interested in is hearing from other provinces that they're paying attention to some of the work we've done around system change. So I'll quickly go through this and work hard at making sure that we've got time for questions. I'm just making sure I've got this right. So why are we doing this? Our system is remarkably complex. We are a small province, so not small geographically. We have huge land mass, but population-wise, we're pretty small, 1.3 million. I mean, if you go overseas and you see how they're looking at systems for millions of people in small places, but also reaching out to the north. Having said that, you'll see in the top left-hand corner the distribution of the population. And you'll also see that we're about a 75-25 split, urban, rural, predominantly urban being Winnipeg. We have in this province legislation for bilingual services. We have, as best data as we've got, about 41,000 folks who openly declare that they are French, predominantly French. And then your First Nations communities are broken down there for you as well. So that just gives you a sense of what our 1.3 million look like. We have 55,000, more than 55,000 staff. So we are the biggest industry in Manitoba. And so when you pause and think about this, and every so often when I have harebrained ideas and get so frustrated when it's so slow, I have to remember that this is a large ship. So 55,000 staff throughout the province. The data, and I've just shown it there, your experience of frontline managers. We've heard loud and clear through Deloitte, but also a variety of contacts with staff. I was meeting with 300 managers several months ago, that managers are feeling very much at risk or vulnerable, feeling they don't have the skills to manage. And I thought that was a really interesting piece that we must pay much more attention to and support. So 71% of our frontline managers don't feel adequately trained or in fact supported. So that just gives you an idea of who the people are, what our workforce is. And then we look at how much money we're spending. So we are spending over, actually now it's about $6.3 billion. So this isn't a small chunk of change. We have a remarkably complex system, and so in taking a look at that, we have funding coming in from several funding departments, predominantly health, but there's a little bit of funding that may come from social services, Department of Families. We have several health authorities, so we've got 5, but we also have Cancer Care Manitoba. You've got all sorts of different agencies. And that just gives you an outline of how complicated it is. And in actually operating our system, we've got more than 7,500 different business processes. So if you think about what it takes to manage this system, it's quite remarkable. So that's just an outline for you. And certainly, if you'd like access, Adam's got this presentation to feel free. It sometimes works and it sometimes doesn't. Can you, Adam, can you operate it?
If you give me the mouse, I can flip it.
Yeah, it might be closer to you working. You can live with technology and you can live it up. So the population we're serving, and I need you to know that when we were doing this planning, all of the planning teams were given information about who we are as a population. So we often talk about our 5 regional health authorities, but look at the differences here. So in the north, that total population in the north, in that vast piece of land is 72,000 people. So it's a small number, but it's hugely dispersed. The Interlake area, most people don't know that that has the fastest aging and the oldest population there is in Manitoba. And if we're looking at some of the issues Interlake faces, that is a loud piece to pay attention to. Southern is our fastest growing population. So you look at Morden, Winkler, Steinbach in that area, and also the newcomers, particularly in the most recent years from Germany and so on, a exploding population. So this just gives you a sense of who's out there and their average age, the numbers, and so on. A couple of quick facts that have certainly influenced a lot of our conversation is that 50% of the patients that are outside of the perimeter actually travel outside of their region for inpatient or day surgery care. So that's a huge amount. So as we talk about Winnipeg, a large number of patients that are served in Winnipeg do not live in Winnipeg. So that really is forcing us to think as a system. Half of Manitobans over the age of 40 have more than one chronic condition. So that's very sad for some of us who are climbing up there. And of that group, 20% had more than 3. So really an opportunity to look at chronic disease management and self-management. And then a quick fact, which is really influencing, is when you look at the prevalence and incidence of diseases. Diabetes is an example. So in Manitoba, we have the highest prevalence of diabetes in the whole country. And when you look at the north, it's double that again. So 7.3% is Canadian. We're at that compared to Canadian average. But in the north, we're well into 13, 14% of the population. Next one. I'm glad yours goes fast too. So what is this all about? And people hear the word cutting. And I'm going to just sort of give you a bit of a sense that actually our budget hasn't dropped. It may not have kept up with some of the cost of living, but certain portions of the money has certainly been redirected in the last few years. So the intention of this is not to cut everything, but to slow down our growth curve. So if you look at these, the bottom 2 lines are Ontario and British Columbia, and the top one is Manitoba. So this line is how much we spend on every citizen. Manitoba is spending the most per capita than any other province. So, and then most people don't know that. And what was happening is we're just keep on going. The other provinces started to bend that expenditure. So in other words, the question becomes, well, if we're spending the most, clearly we've got the best system. That's not the case. So in fact, we're not doing well. And the question is, how are we using our money? Where do we put it? And we don't have a provincial plan. So you will see in the last couple of years, we are beginning to bend that cost curve. But you can see for many years, we kept going up while the other provinces were starting to pull it down. Just so you get a sense, the health budget that we spend in Manitoba is very close to half, 49%. So 49% of the whole health budget in Manitoba goes to healthcare. Everybody in this room knows that health actually impacts the health of all of us less than probably 10, 15%. The biggest impact on the health of every one of you in the room is actually social support networks, you're employed, your income, and so on. So if we kept spending at that rate in 10 years, we would spend the whole provincial budget on healthcare and have no roads, no schools for our children, no education. So this isn't just about us. It's as a health system. It's about us as a community. So for all that money we're spending, There are some areas that we really do well. So this uses High data. And so you'll see that if you fracture your hip, that in Manitoba, you will have that repaired within 48 hours. We're actually one of the top in the country. So hospitalization for conditions that may not require hospitalization, we do very well. Our readmission rate to hospitals, so those people we discharge, them coming back in, we're also doing very well. Readmission, repeat admissions for mental illness. So when you look at this, you'll see, gee, we are doing well in some areas, but take a look that this is all quite acute care focused. The next slide will show you where we're missing the mark entirely. So if you look at our average length of stay, we have the longest in the country. Some would say, well, maybe that's why our readmission rate's so low. We keep them longer. So, you know, those are very interesting questions. Our wait times in emergency for physician initial assessment is one of the worst in the country. So this just shows you where we're not doing well. Take a look at these. Where we're not doing well is more community-based, lower acuity. If you need your hip replaced, you're going to wait longer than most other Canadians. However, if you fall and fracture it, we'll fix it quickly. And so this really is forcing us to say, we've got some really good things in our system, but we have areas that we need to think differently. So everybody's heard about health transformation, and everybody's flipping and flopping about all sorts of things. And one of the most difficult things for all of us as human beings is change. I can tell you that people are all talking about the clinical and preventive services plan, but you need to know, and this is all on the website, so feel free, if you Google health transformation in Manitoba, which is always easier for me to remember than all these websites, it will take you to the site, and on that site you'll see updates, regular updates, but you'll also see what we call the blueprint. So health transformation isn't just about the clinical plan. This shows you a remarkable number of things that are changing around us. And so we've completed wave 1, and wave 2 is underway, and we're still sorting it out. But let me just give you some ideas of what else is happening other than the plan that I'll focus on today. The realignment of Manitoba Health. The role of Manitoba Health is fundamentally changing. So some of you may or may not have seen that the structure of Manitoba Health, all of the branches as we knew them, there was a primary care branch, they're all gone. Manitoba Health is beginning to now focus primarily on funding or commissioning. So instead of handing people, oh, here's your budget, there's going to be far more accountability. So for example, a region will get a budget, but there will be expectations in the budget. There'll be deliverables. Manitoba Health will be looking far more at policy. Are we actually buying the things that we're planning to buy? And so what do those policies look like? What do funding policies look like? So you are going to see Manitoba Health really changing its focus, getting out of operations. So there's several services that Manitoba Health has delivered directly. Selkirk Mental Health, for example, is owned and operated by government. We're getting out of operations and focusing on policy, oversight, accountability. So all of the regions will be accountable still to Manitoba Health, not to shared health. You'll also see up there that there is a lot of work going on building shared health. So I was meeting with a rural board this week, and people are saying, what is shared health? It's we heard in the election, it's another layer of bureaucracy and so on. So I'm going to pause for a moment because you'll see one of the work packages has been really taking a look at shared health. You guys know more than I do, but you know that DSM was a separate corporation And it was actually that structure. We haven't dissolved the role and all of that work at all, but it's no longer a separate corporate entity. So there's clearly a move to try and getting us to work better as a system. So as DSM disappeared, shared health appeared, but those resources came together. So shared health isn't a whole bunch of new. I mean, I always laugh and say shared health is actually about 5 of us right now. So I think people think there's this big something. I'm going to just pause and explain shared health because I think it helps the rest of this. There's 3 functions of shared health, and I don't think people are clear about those functions. One function is lead and coordinate. So we have been tasked with leading and coordinating the clinical plan for the province and the quality framework. And lead and coordinate doesn't mean we're doing 4. Leading and coordinating means every region, all the service delivery organizations are included. So our role is actually to facilitate coming together so that we can lead and coordinate a better systemic approach. So that's the purpose of the plan. The second function shared health has is exactly the same as every other region. So we'll call it the service delivery function. And there's 3 big buckets of service that we're responsible for, just the same as every other region. So we're not better, they don't report to us, we have to work the same. One of those is the provincial services, so predominantly Health Sciences Center. One of those is Lab DI that you know has become provincial. And the third area that has become provincial is emergency transportation. So that used to be all quite fragmented. So that includes, everybody's heard about Life Flight and so on. So it's provincial. So we've got a provincial approach to emergency transport. And the third big function of shared health is shared services. So legal, for example, the only place that had legal services was WRHA, and all the other regions had to go somewhere else. So that's coming to shared health so that we're supporting all of the regions. Purchasing, health human resources, digital health, no longer as WRHA, it's provincial. We must start looking at systems, you know better than I, but systems that are provincial. So think of shared health as having 3 functions. And what I'm going to talk about today is the lead and coordinate function. So this, feel free to dive into all the details, but it's just so you know, when we're talking system transformation, it really is system. Next one. We've had an outside person from Australia over who's actually does a lot of international work. And his comment was, given the size of our population, we have an opportunity of a lifetime to actually change things. So he was extremely supportive and has been really helping bring ideas, not just from across Canada, but from around the world. Next. So the plan. Everybody's been talking about the plan and who did the plan and so on. So 11 provincial clinical teams were struck. So you'll hear, oh, in healthcare we use acronyms. So I'm going to tell you acronyms. PCTs are provincial clinical teams. These teams worked together, but they each had their focus. And each team had representatives equal from all of the service delivery organizations. It's the first time that planning had equal representation throughout Manitoba rather than by population. So it was fascinating to me, I'm a little long in the tooth in healthcare, to really hear the equal voice of the North and rural and remote. Each of the teams had a focus and involved all of these teams involved about 300 clinicians who then went back and spoke to their areas. Where's lab on every team? Where's Aboriginal services on every team? So you need to know there are key pieces that clearly traveled across teams. These teams included the 5 regional health authorities, 75 hospitals, 121 long-term care facilities, 362 medical clinics, and 22 cancer care sites. Just so you have an example that we scratched our heads saying, how the heck are we going to do planning given that? But we tried to make sure that the representation was interprofessional, interdisciplinary, and certainly geographic. You'll see some of these teams tend to be disease focused, so some of the mental health and addictions. Some tend to be more populations focused, so women's health and so on, and some around service optimization. The most fascinating thing for me was watching the teams realizing trauma. We can't plan trauma unless we know what community's saying. We can't plan trauma. We need more IT support at our table. We need lab. We need DI. So we actually held one meeting where we had all 300 of these people in one room. Each team had to make a big poster, what their issues were, what their plans were, and we forced everybody to go around and meet with each other. So we were identifying cross-sectional things. Now keep in mind we had to do all this in a year. So it was a fascinating piece, and the task for all of those together, and we had Deloitte helping us. Thank goodness, we could never have done this. It was really to have one provincial plan. This province has never had one plan. Each region does a plan, and it's been fascinating as somebody who's lived through regionalization and watched this, is pretty soon regional boundaries actually became boundaries to access. Sorry, you don't live in our region. Sorry, your mom's over there. She can't access palliative care here. She has to go there. It's been very interesting. So this truly has been to look at how do we provincially organize our services while we still have the regions, because you do want local input. But the region's role is now operating, not doing independent planning. This is us coming together. So we've developed a plan. Let me tell you a few things that we heard, and I think you'll certainly identify these. You know this as well as I do, but it was nice to see it on paper. So these are the emerging issues, the next slide, that we heard from every single team. Long wait times and inequities to access. So depending where you live, depends where the access is. Unsustainable operations, so we heard from throughout the province, we can't just keep going on this, we don't have the staff, there's full scope of practice issues. The pathways across providers is remarkable. So we tend to work in a system that's referral bound and everybody has referrals, and how do we work as a system? Huge issues between generalists or primary care and specialists, and a real imbalance, and how much time do you have to wait. This actually, just came back from Ottawa yesterday where we're looking at patient safety across the country, is a huge patient safety issue as well. Limited tools to support alternate models of care. So we have done lots of introduction of alternate models in Manitoba, midwifery, different model of care, physician assistants. We've got in Winnipeg, priority home, new model of home care, but we really haven't had resources to look at those and to support those. Inconsistent care delivery, patient risk issue, certainly a misalignment of clinical capacity to patient needs. So our most stressed population is our Indigenous population and in the North. So I think all of you saw the report that Dr. Katz released on Wednesday. And so as a population, we are getting healthier, except our Indigenous population is getting less healthy. So we have an increasing divide, and where the majority of our First Nations people live isn't where the majority of equal access is. I've already told you we've got a finite resource scope. Loud and clear providers, particularly in rural and remote, but it certainly occurs in Winnipeg, feeling they're not able to or supported to work to their full scope of practice. And then limited collection of performance data. And I'm just going to put a flag here is Manitoba is actually very data rich, and in some cases information poor. And that's why reports like Dr. Cates' report and so on have been very valuable. So out of all of these, there are huge opportunities, but it means we need to work differently. Coordinated access between generalists and specialists. So how do we bridge that gap? How do we maximize technology? A lot of work going on across the country around e-consult. The data from e-consult is remarkable. It has decreased remarkably the need for people to travel to a specialist. It's increased the response times. So that whole piece came across loud and clear. Consistent pathways. One of the biggest risks to quality is variability. I'm speaking to the converted because I'm so impressed with the data and the performance reports that we see from lab and DI. And actually I've been using a lot of the dashboards that were previously DSM, and I've been working that group. But across the system, we do not have consistent pathways. There's not a consistent pathway to get to an endocrinologist or to other specialists. So it varies depending on where you live, who you know, who's got relationships with you. How do we take a look at that? The whole digital health enablers, so digital health sat on all of these teams. We've heard loud and clear, we forget that we have many spots in Manitoba, there is no access to anything, including cell phone. So what does that mean? We also forget that those in Winnipeg who assume that everybody's got access to technology we do is the same. Who knew? There is no electronic record for home care. We're just working on that outside of Winnipeg. We can't collect the data. So there's all sorts of, even in Winnipeg, it's inconsistent. So we heard loud and clear opportunities and how do we work together, and how do we actually think differently? How do we do telehome care? How do we do things that we may have never thought about? So these are really just ideas that came through that as these teams said, here's all these issues, they also came back and said, we've got opportunities. We need to turn the barriers into solutions. Next slide. Indigenous partnerships is important. So many of us here, well, it's all between jurisdictions. It's not just the jurisdictional issues. We have more than enough evidence about systemic racism. So running beside all of this, supporting every team, was an Indigenous partnership strategy, and that will soon be released. First Nations peoples have been involved and have looked at all the planning. They have absolutely supported the planning, but they're very clear, don't expect us to just adopt everything. We want to be jointly engaged. So we are moving into a very different era around working with our Indigenous people, far more involvement, and that too will be coming forward shortly. Dr. Kathy Cook led this along with the ADM, Avis Gray, because we are very clear it's not just our practice issues, but government, Manitoba Health, needs to also tackle the policy issues with FNI. But we can't say we won't do anything with practice while we wait for policy. We need to keep working on this. Next slide. So, working together, what does the high-level plan look like? So you need to know the planning is being completed, and planning, we use the word rolling. So this plan now has been presented to government. There were no releases because of the election, but I am sure fairly soon you will hear some key pieces coming forward. I can tell you key priorities are certainly mental health and addictions and Indigenous health, no question. And so, and that's certainly we've seen also with bilateral funding with the federal government, there will be some new announcements around mental health and addictions. At a very high level, we have got a framework that has been put forward that is integrating models of care within levels of networks. In other words, trying to rationalize the whole system to ensure that we're looking at equity. The first hub or network is the local network. So local networks need to be throughout the province. This is our opportunity to do something we have not done, and that is better integration of all community health services. And so your question likely is, and what do you mean? So my latest, because I am a patient, you are all patients, is community services are any services that I can receive when I'm in my own bed. Family medicine, home care, community mental health, public health, and we're actually also including personal care homes. That is your own bed for that period of time. So we are looking at local hubs. They will look different depending on the community. So a far remote community may have a doctor and a nurse practitioner and a community health representative. Another community may have home care and public health and a long-term care facility, but we are looking, how do we bridge those and move away from a referral system, a referral to home care, and you might wait 3 weeks, you might wait 6 weeks, that we actually start building teams. The next network is a district health hub. Chances are in a district health hub, you would see an emergency or an urgent care. You would see a low acuity hospital. So in rural Manitoba, these are quite common. But I think you will also see more standardization. So I don't know if you know that we have over 60 emergency departments in Manitoba. 16 of those have been on long-term suspension. That means closed, but we don't use the word closed, because if you say closing emergency rooms, there's all sorts of community worry about that. Did you also know that out of those ones that are open, that last year we had 3,500 unscheduled closed days? So that meant that if the doc was sick or something, all those stuff were there, but the emergency had to be closed. Some emergency rooms are open on Tuesday afternoons and some on Friday afternoons. So this really presents a problem to communities. And it's fascinating to me when we have met with every single municipality in the province. We've been in town halls. Rural Manitobans, a farmer came to me and said, if my hand's caught in an auger in a field, now that I know that paramedics are trained, I'm not going to try and get it out myself and go to emergency because I don't know which one is open and I don't know what their skill sets are. And now that rural Manitobans are understanding the increased role of paramedics, they're beginning to ask for more predictability in emergency transport. So if I call 911 and a paramedic arrives, they're now trained enough to start treatment right there. And if your hand's in an auger, probably they'll call STARS because you need to get to trauma, not to the local hospital. And it's fascinating to me to watch the public becoming far more aware of all of us and how we deliver service. The third network is an intermediate hub. So that would be a higher acuity. Probably in an intermediate hub, you see an intensive care unit. So Grace Hospital, Brandon, Thompson. Does that mean that we need to actually invest in Thompson so that it can do other things? And so this is really looking at strategic locations. And then a provincial referral hub. So again, we're a small province. We're one of the few provinces that has one tertiary center and one geographic location. So I don't want to say Health Sciences Center. Health Sciences Center is a building. It's not a network. So there are also provincial services like cardiac at St. Boniface. So there are other provincial services, so Selkirk Mental Health. So to think about provincial services where we won't see them dotted around, there will be a hub because of the degree of specialization. So that is what has gone forward. I can also tell you that the groups identified where we need to do a lot of work first is the local hubs. So instead of having everybody going to the emergency department for local services, primary care, and all the data shows us that, we need to really pay attention. How do we build or reinforce the local hubs? So many of you have heard of my health teams. They're expanding. They tend to involve family physicians, and it's actually taking all that work and building it. These are just very quickly the categories of strategic shifts. So I've said we need to enhance our local capacity. Very interesting questions from small communities. If our emergency department's on long-term suspension, shouldn't it become a community health hub that has better primary care or more home care? Because that also is very variable across the province. So it's been very interesting to hear communities actually coming up at these town hall meetings saying, how can I help you? Very interesting, a very different change of engagement. Increased access to specialist care, so that doesn't mean always appointments, so really taking a look at IT and so on. Building care closer to home, how much day surgery actually could be occurring outside of Winnipeg, and looking at different hubs. That means that we invest and have, a common standard of care. Provincial practice improvements, we have a lack of standards and pathways in this province. Why are there 30% more C-sections in Brandon than Winnipeg? If you have a hip replacement in Winnipeg, the same practice should be in wherever it's provided. And how do we look at pathways so people know how to get to places? So I think we just all assume we work as a system, and that's not the case. Effective chronic disease management. We are an aging population, more and more chronic disease, but the evidence is loud and clear. Self-management is very effective, and continuity of care has the biggest impact on effective chronic disease management. So how, again, do we build the local hubs? As I said right at the beginning, you can see where clearly diagnostics, we need to look at how, and Peter Crest has been working on this, but how do we work as a system and look at access? Prevention, people were grumpy at a meeting I was with last week. You've taken prevention out of CPSP, which is a clinical preventive service plan. That's not true. Prevention is very important. But remember, we don't have buckets of money looking for a home. Here's our opportunity to redirect. Are there things we should be doing differently? So this just gives you, in a nutshell, these strategic shifts. And this is really just another diagram, and like I say, you can certainly have access to this PowerPoint of what I said about the different levels and what you might see in each of those networks. So running along beside all of this, many of you know that I am absolutely committed, and it took me a long time to say health transformation must be about quality. So everything we do. So you will see, if you go back to that really busy slide with all those activities, quality and learning has been a project, and we have finished most of our work, not quite, but 2 big pieces have been finished, where we were clearly a project, and we have taken forward with input from all of the service delivery organizations. LabDI was there, and we really came up with a framework that actually aligns with a federal framework that's going to be announced in the next few weeks, but also aligns with all of the work we're doing. So I'm particularly proud of this because I saw people come together in a way I've never seen before. Next slide. So the case for quality, Adam and I both sit on the MIPS board. So patient safety is a piece of that, but we can't afford not to look at quality. So it's frightening. We were looking at these data yesterday at a national meeting, but 1 in 18 hospital stays will involve at least 1, and sometimes 2 or 3 unintended events. So this is about how do we start looking at the systems. So it's 37% of those are healthcare, medication related, 37 are infection. Everybody laughs about hand hygiene, and I just, I think we underestimate how many people have hospital-based infection rates. And it's because washing your hands is a behavior. And people pass it off, but we're trying to change behaviors. And quality is changing behaviors. Next slide. Here's the costs. Unfortunately, people who are poor have much poorer outcomes. And unfortunately, people, in particularly our Indigenous people, experience far more patient safety related incidents than the rest of us. So it's fascinating data, and we'll be looking at that further. In terms of the overall system, 1 in 10 visits or touch points with the system, so not just the hospital, but your doc's office, home care, 1 in 10 will have an adverse event. These are shocking numbers. And then when you look at that, the average in Canadian dollars is between $6,000 and $12,000 per event. So some events may not cost us anything, some thousands of dollars. So when you take that now to government saying we need to bend our cost curve, I'm on the prevention side saying, you betcha, we can't afford not to look at quality. And then it's our staff. I mean, staff satisfaction is about delivering good care. So we need to pay attention to staff and supporting staff and the good work they do. Next one. This is the framework. I will go through this quite quickly. What we heard, so remember, safety is board to ward. It is all of us. And we heard people say, can you please keep things simple? And I like simple. So in the middle, there are enablers, and we need strong leadership and performance measurement and so on. But what we did ask the folks to do was talk about what do we mean by quality. And we actually surveyed different folks throughout the province. Everybody talks differently. And there was a critique in the Deloitte report that said, we don't know what we're talking about, quality. So what you'll see here is 10 dimensions. Those are the little things in the boxes. Those 10 dimensions, 8 of those are aligned and consistent with Accreditation Canada. So this is aligning with what people know. There are 2 new ones that the group have been adopted. One of those is workforce. So the Accreditation Canada one is works life, but workforce is where do we have no staff? Did you know there's some areas in the province that has 100% vacancy rate in home care? And then in the north, we may not have access to physicians. And the other new one is equity, and I'll talk a bit about that in a minute. We then, because we heard loud and clear from people, can you make it even simpler? We use the IHI, the quadruple aim 4 domains. So we aligned the 10 dimensions into 4 domains. One is positive patient experience. So the outside domains are what IHI calls them. The inside is what Manitoba calls them. So patient experience, the Manitoba objective is a positive patient experience. IHI talks about reducing costs. In Manitoba, we're talking about a sustainable health system, linking back to why we're doing this anyway. The third one, the lower left, is healthy teams, or IHI calls it care team well-being. And the last is healthy Manitobans, or population health. So those 10 dimensions fit beautifully into 4, I call them buckets. Next slide. This isn't about acute care, it's about everything we do. So we need to pay attention to quality on the prevention side of the world to end of life. Quality is across everything we do. Next one. Very quickly, enablers. So you'll see here how we've defined the leadership and the shared vision. So I'll just leave that with you, but we must have leadership that supports quality and holds all of us accountable, but provides us with learning and support to move forward. The next one is the performance measurement. So here's where I talked about the clinical plan. Well, we better know what it is we're trying to achieve and how we're going to measure it. So we do really feel that performance measurement in all of those domains is important. We need to support our leaders and our staff. We need to dedicate resources to quality improvement. So a dashboard is only as good as it is used for quality improvements. So I always tease people, I've got a dashboard in my car, and if the fuel light's on and I ignore it, so keep in mind, dashboards are great, but I want to know what's behind the dashboard. And the last enabler is standards. And I said earlier, with increased variation, we have decreased quality. So we really are looking at standards. And these aren't just national standards, but clinical standards and so on. So the last thing I did want to talk about is clinical governance. So the framework is helping us all define quality. That's fine. Then we've got this plan. That's fine. And we know what some of the priorities are going to be, and you will see some definite actions coming out of that. How on earth are we going to do this? So we are right at the cusp of really formalizing provincial clinical governance. So we've never had that in this province. Very few provinces have formalized this, a little bit in Alberta. And certainly if you also Google this or look at provincial clinical governance overseas, you'll see it's highly formalized. Provincial clinical governance is really two key functions. Well, I'm going to say one key function. The main function for provincial clinical governance is quality. And notice I'm saying quality and learning. So in all the quality work we've done, we've taken the word of training out. So I've now figured out that those cute dogs outside, I bet you they all went to training or puppy training classes. We don't train people to do quality. We teach and we learn and we mentor. So really moving this into a learning frame. Everything we do has to be learning. Critical incidents must be about learning. So here's where we're bringing the clinical governance in. So here is the evidence on clinical governance, but really the clinical governance is about quality, and we now need a structure that's going to support the quality plan. So if we come up with a new pathway because the clinical plan says we need better integration between primary care and specialty care, that requires a new process that needs to be monitored. We need to teach, we need to learn. So this is bringing it all together. So it's through clinical governance that we will implement the quality plan. So in summary, the PCTs, the provincial clinical planning teams, will evolve to become, but won't look exactly the same, so they will be slightly different, but will evolve to become provincial clinical networks. Those networks will have input from all throughout the province, and likely will be led by, a clinical expert, and probably that person will be a university appointed lead, like a section head or at surgery, but those teams will be interprofessional, and they are going to be supported with two key areas of support they need. One is content expertise. And the second support they need is quality and learning. So some of you may have seen 4 positions. So this is the first time Shared Health is actually hired for the learning side. 3 of those were clinical integration provincial leads. The job description's the same, but these are going to be content experts, and we'll likely see a blend of expertise. So one of those 3 clearly will need solid background knowledge and expertise, clinical knowledge in acute care. One very likely community health, home care, long-term care. But we deliberately haven't made those separate, that those 3 need to work as a team. So remember, those clinical planning teams said, wait a minute, I can't do a pathway and a standard here unless I know what's going on over here. So that's going to force the system. And the 4th position that was posted and will be filling very soon is an executive director of a quality and learning division. Those 4 people, their big role is going to be to support clinical governance, to help us work through. So quality and learning is not going to be a department out there somewhere. Quality and learning belongs in each of the areas. Lab, you've got, fabulous quality folks, and all of those remain the same, but we need a lead and coordinate function to bring it together. And lastly, I'll tell you that on the quality and learning side, there will be 4 key pillars of that. One will be accreditation and outcomes. We do have approval that we will be moving forward for the system accreditation to a provincial approach. So instead of everybody doing their own, we'll be leveraging accreditation, so it's no longer a happening, but a process. So instead of waiting for the surveyors to come, it's about self-assessment. It's about quality improvement planning. The surveyor visit is a peer review. We'll be doing that provincially, but every SDO still has the same role, but we're going to coordinate it. So if we're looking at surgery, for example, we'll be looking at surgery in every region that delivers surgery. They'll each do their own self-assessment, but we'll then share those self-assessments so we can see where there's strengths. How do we work as a system? So we're going to be spacing that out over the 4-year cycle, and we'll be moving to 1 provincial contract for that piece. So the roles of everybody is the same. We're not doing it for people. It's going to involve more, but we're going to try and coordinate it. I know the rumors out there that people said we're going to accredit labs and DI. That is not true. So it's just amazing. But we've got 2 big pieces of work left to do: accreditation for lab, diagnostic imaging, and non-invasive cardiac testing. And we're working very closely with ManCap. But the first job we're doing is an environmental scan. So we've asked the Center for Health Innovation to go forth and talk to people across the country. There is so much work going on outside of Manitoba. So we're really wanting to learn and share and make sure we're lining up. We may be partnering with. So the first thing we're doing is a complete environmental scan, gathering all the evidence, talking to all of the other colleges, talking to other associations, and then we're going to map all of that out and develop a group to help really come up with a series of recommendations. The second major piece of work that we're doing is personal care homes. So they also have a different process in Manitoba where they do provincial licensing or provincial standards as well as accreditation. And we're trying to bring that together. So the same approach we're taking, let's do an environmental scan, let's ask what the other provinces are doing and what we've learned. So that big piece is moving forward. And at the end of the day, we've got the framework and the systemic pieces. Those have been approved, moving. The others are work underway. So what's happening now? System as usual. So everything's in place. This is not about lifting and shifting. So one of the key pieces in all of the transformation is this isn't about just lifting and just putting it somewhere else. about how do we do better. And I'm very keen on making sure whatever occurs with Lab and DI, you are a key piece to the system. So we want to make sure that you're also linked with and involved with systemic accreditation so that we don't have parallel systems. So the last comment is all of us as health providers have two jobs. One is the delivery of care, and the other is to make sure that care is safe and so on. Here is the website for health transformation. That website always has monthly updates. So I hope this helps just give you a system perspective. I've really enjoyed getting to know Adam on the MIPS board, so we've been working closely together, and I can tell you I'm joined at the hip with Peter Kresta and Peter Chukowski. Like, we do lots of work together. So I've actually held the quality accountability for Lab and DI out as the pillars. So questions? Does this make a hill of beans to sound? Hi, yeah.
Can we get them to come on too?
Thank you for the talk. It's very informative.
Yeah.
You have to come up to the mic because the rural people won't be able to hear the question.
Just state your name and my name is Jeanette and I work at Cancer Care Manitoba. And I think what worries me is we have two different definitions of quality. My mom ended up in urgent care in July for a bladder infection. There was 3 other women in my mom's age. My mom's 92. The other 3 were 80. They only knew this as their other, they couldn't get in to see their doctor, so they knew that this is where they had to go. We arrived at 7 a.m. We didn't leave till 6 a.m. the next morning. That, to me, is not quality. And I understand, I'll be the first one to say that things had to be done. People were going to emerge for unnecessary reasons. One of my other concerns is it's not even flu season yet, and now the city only has 3 ICUs. What if there's an H1N1 outbreak? What would they do? I'm asking you.
I think those are excellent comments, and those are exactly the reasons we're trying to put together a system plan. I can't sit and answer details about emergency and urgent care and so on. I too have a 92-year-old mom who is in urgent care. I think that some of the things we're seeing are promising. So some of the wait times for the less urgent pieces and in urgent care. But I think you've raised another really good point. Why are there so many people in urgent care at all hours? And you said it. I can't get into my family doctor. So hence the discussion about those, about local hubs. So in Winnipeg, we, and in rural Manitoba still has some, we have quick care clinics, and I mean, everything gets caught in politics. But there are connected care options. But I'm going to say more importantly, we have much more to do to support primary care in being open extended hours, advanced access. So it's not good enough to phone and say I'm sick. Well, you can come in 2 weeks. So that how do we actually support that? And we're beginning to see a bit of change through the My Health teams. But your examples are exactly why we need system change.
And I'm not blaming the staff. The staff are working hard. They were working short. Why is there only one physician in urgent care who's also responsible for the patients upstairs? That is just not. And I guess what I'm worried about quality is the education is going to be working with less. As sorry as I am to say, because a lot of us would like to spend a lot more time on what we're doing, but we just don't have that time because it seems like it's in and out now. That's it.
Yep.
Hatch, patch, and dispatch.
Thank you very much for those comments. And those are exactly the issues. So as a provider in the system, actually also as a cancer patient, And as a caregiver for my elderly mom, absolutely. And I think, so I'm quite open to sharing my own experience as a person that went through my own experience. I also identified things that were working well. I had such a hard time to get anybody to hear me. And so my other learning from all of this is where we are doing things well, we're not taking a look at those. Now, I said to somebody the other day, when you get a card of thanks, does anybody do a root cause analysis? In other words, we can find all the things going wrong, but there are pockets that are going right, and I don't think we are learning from them and becoming strengths-based. And so I'm hoping that as we see more, and I've been working on some national committees with patients, that we also hear patients' voices about what didn't work well, what did work well. So if in fact something worked really well around a response time or a staffing pattern or linkages with technology, so I'm just telling you, I just found it fascinating. I had a really hard time to find anybody who would listen to the positive, not a hard time in finding a place to register a complaint. So thank you.
Thank you, Jeanette. Adam?
Before Noelle says her question, I had a comment that relates to what Janet commented. You had the slide with the 4 quadrants, and one of the quadrants was the one about team health. And when we're doing I don't do them, Trish and Janelle do the audits of our portfolios for continuing competency. One of the biggest comments we see in those, in the self-assessment, is that people are stressed out, burnt out, overworked. The workload is getting bigger, the resources available are getting smaller. And you had that one slide following that related to costs, and it mentions that you can't reduce staffing levels and increase workload without a result in quality. So as a college, we're always, when we see those kind of comments, we are very concerned, because we know that, and from MIPS and patient safety data, that when people are stressed out because of increased workload, increased stress, there's a higher risk of quality and critical incidents. So I'm very concerned about that, and as a college, and I would like to see or find out how is the system looking at that, because historically, lab has always been at the bottom and always the first to get cuts, always the first to look at where we can save money from lab and DI. It sounds like there's more resources being put in looking at how do we make the whole system better. You know, in my mind, in order to make the whole system better, you need to look at the whole area that is is underpinning the whole system. 70–80% of clinical decisions are based on diagnostics. You can't do what you're doing in clinical without getting diagnostics. And if there's a risk of quality, how are we looking at that?
Absolutely. And I also think it's time to think about the role of regulatory bodies. So I have met with the Alliance, because this isn't about one regulatory versus another. And I'm going to be brave here and say we've got another issue in our system, and that's systemic racism. So I alluded to that. And I think we will be increasingly held accountable to our patients. So I think we need process redesign. We need to talk about these things. Our proposal, which has also been accepted, is to create a Quality and Learning Alliance. That is an advisory group that advises government on policy, shared health, on some of these lead and coordinate pieces. On that alliance, we have also said that lead and coordinate the quality and learning division needs to support that alliance. That alliance, we have clearly articulated, needs to include the regulatory bodies or an alliance of the regulators, because I think the voices that you hear, the concerns you have related to competency, so I've heard the same concerns about teams and so on. I've also heard concerns about cultural safety and racism, just so you know. And the regulatory bodies are coming forward with suggestions. And I think that's what we're looking for, advice. The other large body we need to involve more is our learning institutions. So we have also said that on that provincial advisory group, we need the educators, because we need to think about people behind me coming into the system and what are we doing around the change. So Adam, I think your comment is a good one, and I can tell you that that has not escaped me, and I'm trying to find ways to pull that in. And it's certainly on the overarching agenda, absolutely.
Thank you, Adam.
I'm Noelle Cater, and I'm from Winnipeg. I actually was going to comment a lot about the basically for primary care and the concerns about that. Just what I've suggested before in some of the surveys that have gone out and stuff is really we need to have, like you said, extended hours for clinics, because that's the draw on the emergency and even on urgent care. In some cases, I think that could be taken from some kind of access clinic that would be available other hours, that's available longer hours, or however we need to do that.
And did you know that we actually now have walking connected care throughout the city, but I don't think the WRHA has let the public know.
Yeah.
So the quick care's closed. So, and just so you know, I couldn't agree with you more. I dug my heels in deep and said, wait a minute, it's not about, I've always said, maybe having a separate building for quick care wasn't the best. So we actually said those quick care were extended hours. We integrated those. So Winnipeg West has extended hours, and we called them WIC, Walking Connected Care, based on what the public told us, that we didn't want to, so help me help people know, we didn't want people to think we were endorsing walk-in sporadic care. That the walking connected care clinics, so Access Fort Garry, Access Winnipeg West, Access Centre de Santé, Access Northwest of the North End, they are open those extended hours and weekends. We're trying to also engage other family physicians, but their job isn't just to steer you for the urinary tract infection, is to communicate with your family doctor that you came in, because not every clinic's going to be, and here's what was prescribed. And that information, if you are a home clinic, is now available on eChart, just. So this is a fundamental system redesign, but we need to let the public know.
So that's helping with continuity of care as well. So
Absolutely, absolutely, based on exactly what you said. So this has been my quest for 40 years, and if we...
No, it's very frustrating coming from patients and caregivers. And also, I just thought that was a very big concern about the emergency preparedness. So does Shared Health have a plan for emergency preparedness?
It's provincial, so remember, Shared Health certainly coordinates that. It is pulling all the others together, including with Manitoba Health, who remains responsible for the provincial public health. So anything we do around emergency preparedness is done with them.
Okay.
So it's not just emergency preparedness in the event of an outbreak. We also have another major issue that we need to make sure, and that is an event of a highly contagious disease coming in. So yes, and Helen Clark with emergency transport, along with others, Dr. Perry Gray, have been heavily involved in that is moving out.
So that's good to know. Okay, thank you.
The good news is the latest that I heard last week is we always base on what's happening in Australia, but the flu doesn't look as severe as last year, but touch wood. That might be all the rain that we have to worry about.
My name is Megan McDonald. I live in Winnipeg. You had mentioned the challenge of staff dissatisfaction and burnout, and in delivering quality care. Are there any plans to address the challenges of specific staff dissatisfaction and burnout, disillusionment with the delivery of poor quality care? I work in the second largest hospital in the province, and it's quite demoralizing to have to call all of your emergency and intensive care wards to say, I cannot offer you a sodium for the next 2 hours, I hope. Maybe. You know, and they have real questions. They say, well, what are we supposed to do? I don't know. Are there any plans for that?
So we're diving into operating plans, which is not in my scope, but I can tell you a couple of things. So each of the, you know, in your case, and I suspect your organization, the actual institution is responsible for the operations. However, I think there's something that's been sorely lacking throughout the system. One is engagement strategies. Like, I mean, people, I was really discouraged last week is that not knowing uses up a whole pile of unnecessary energy. And how do we hear the voices to help in the planning, but how do we communicate? And Winnipeg, unfortunately, every other region, we have met with all of the staff. And Winnipeg, because of the clinical consolidation, hasn't had the same exposure to all of that piece.
Is there plans to have one of those?
I've been doing, I am one. So yes, and we've been meeting with the WHA. We have met and presented this on the quality framework within the last 2 weeks to all of the CEOs and the WHA executives. So we've done all of that. So we go on invitation, but I think I'm seeing more of those invitations. Like, I think you guys are actually ahead of the game, so you're out there and talking. There's another thing that has worried me is what we heard earlier about managers not feeling supported. And so if the managers aren't supported and that communication and engagement isn't happening there, you feel it right at the coalface, of course. So I've been working with organization system design and also with Beth Beaupre. She used to be the ADM. She's now leading the health human resource planning. So things like, and again, I will not use the word training. How are we supporting better communication? Leads training that is not training, but a strategy. Lean, how do we look at processes? I mean, one of the things I've learned in my own work is, as much as I hate to admit it, perhaps the way I was doing things before wasn't the best and we were able to streamline, but without support, you'll never get there. Like, you don't have time. So I hear you, and I will continue to take that message back. Absolutely. Absolutely.
Hi, I'm Kamran.
Hi, Kamran.
I'm from the rural area and playing from Manitoba. It's very nice presentation, and I see the graph for the Manitoba is higher than the other province. But I have a question regarding the Indigenous and First Nation people. They, because of the largest population in Manitoba, and they are, I don't want to say, okay, they are using a lots of budget for the health fund, but they are on the isolation areas and stuff, no education, any literacy, any education they are planning to do. This is the major part for the Manitoba is rising the graph. What they are concerned, what they are planning to do to bring it down, and it's make a big impact so we can able to compete with the other province.
This is hard for me to say. we are experiencing long-term results of years of racism. This is not going to be resolved in my lifetime. We have a huge generation that was in residential schools and therefore never had parenting. We have got cultural dissonance where we, and I'm not meaning, but I mean the collective Canadian we, tried to take away culture and assimilated, and we now have the highest rates of mental health, drug addictions.
Yeah.
So we as a society are going to have to come to grips, and it's hard work, and I've been doing a lot of work with BC on this. It is hard work, and it took me a long time to say, I am racist. I am a white person that sees the world. So there's a lot of work underway. We're seeing a much higher number of First Nations people in university. Remember that our training system and education system is also very colonialized. So some faculties are actually changing those pieces. We have to have far more First Nations involvement in planning, and I'm going to say ownership. I think you will see an increasing number of First Nations communities running their own health. And that's beginning to happen in other provinces, which is another change for us. So how do we partner with those? And you are right, it's about education, it's about parenting. With mental health, we now have a position that is responsible directly to central government, because until we figure out how we change what we do, so health does this, justice does this. So we are now coming up, and you're going to see in the next few months, I think, many announcements around we have to function differently as a system. We have to build capacity of our First Nations to take control of their own health, but we have to build capacity. So until we build that capacity, I mean, we're suffering poor health outcomes. What makes me sad is watching them get worse instead of better. I think you will see, not I think, I know you will see a much greater voice. And then I think the other thing that we have really been doing is promoting cultural safety. All of you should have access. If not, let me know. There's an online cultural safety training that each of the regions has supported. So we have spent a lot of time and money with the folks in BC. So we've Manitobaized it, because I think part of it is stopping and understanding ourselves first. And then, so I hear you, it's a complicated.
I know it's a complicated one, but the government take the good action here for the health system. And they don't they try to work harder. Not everybody is happy, but they still try to implement it. So same thing, I want to see the procedure over there. Not okay, for that reason, but they have to take the tough steps in order to be maintain the budget for the health.
And I think that's where we need to keep doing work in Iviscray with First Nations. So given that FNI funds a lot of the First Nations pieces, and historically that system's been very paternalistic, so I do work with First Nations communities up north and rural and remote. So this is a long, complicated journey. I don't have a simple answer other than I'm sharing with you what I've learned to try and move forward.
Okay, but this is my thinking, this is my attention.
Yeah, no, I think.
And then 90% budget, we spending from.
Absolutely.
Thank you.
Absolutely. Thank you very much.
Do you have any questions for online questions? Anything online?
No one's typing anything.
I don't have audio unmuted.
There's no questions. No questions.
No question.
Hi, my name is Reese. I'm live in Winnipeg. In one of your slides, you compared the average wait times in Manitoba compared to other provinces. And I was just curious did you identify the reasons why like our wait times are longer compared to other provinces? And as you said earlier, Manitoba is like compared with the population of other provinces, we're like a small province, right? And is there any specific reason that you identified, like why is that the case? Is it the lack of rooms, lack of doctors or physicians, or like certainly it's like our population, as you said, is not as big as the other provinces, right? Like, and I'm thinking that like the number of patients coming to the emergency departments in our province, it's not more than the other provinces, right? So, like, and if you did address those reasons, like what like actions or what were your plans addressing those reasons?
Good questions. So those data are from the Canadian Institute on Health Information. So they don't dive into the how. They just say, here you go, your provinces. So your question is exactly what each of those planning teams were said, go away, and what is this data telling you? We also had Deloitte look at all the other provinces saying, the provinces where the wait times aren't as high, what are they doing differently? So what you will see, so I want you to know that work is being done. That is exactly what we need to know to change what we're doing. So that's what you will see in the implementation and in the plans. Yeah. But your thinking is exactly what we did. So we were given these data, and we were told as 300 clinicians, go away and tell us what you think the issues are. Then we had people diving into the data, the planning will come forward.
So obviously, because like right now, like we consult like all the emergency departments, like most of the emergency departments, they're closed and they convert it to urgent care, right? So like, will that be the best solution to address all of these problems we're facing, like especially for the longer wait times in emergency departments? So
I'm going to be biased.
Yeah.
People always talk about the emergency department wait time is the indicator for patient flow. And I always just shake my head, and you need to know the whole country is now changing their mind, is that's not the indication of patient flow, it's the system indicators. Do you know there's 3 emergency rooms in Vancouver? So how can it be that, and the other piece in my mind is we don't have enough specialists nor a big enough population to have trauma everywhere, and like we need to be smarter. But my bigger worry is building more emergency rooms because of wait times isn't the solution. Understanding who's there that shouldn't be there. So several years ago, I ran data on this. Half of the visits to the Concordia emergency room were primary care, like 50%. So the question then becomes to what somebody earlier said, wait a minute, they're there because they don't have access to this. So I think the questions are good questions, but we need to say, okay, who should be there for what? Here's another interesting piece of data. We've got waits for personal care homes. So everybody in the paper, we're looking for promises to build more nursing homes. Do you know we've got the highest number of nursing home beds per capita than anywhere else in Canada? So I asked myself, how can this be? And sure enough, when we looked at the CIHI data, the acuity of people in nursing homes is the lowest in Manitoba. So now you have to say, are we a province that actually is doing all the wrong things? Like, so there's a waiting list, let's build more. Wait a minute, let's find out who's there. Why are they there? So in Winnipeg, they opened up Priority Home, which is intensive home care with rehab and discharge. So we no longer put people in a hospital bed waiting for a nursing home. They discharge with Priority Home. How many of you knew that 6 months ago we had over 60 empty personal care home beds in Winnipeg? So that's a really good example that if we had said the wait times to the nursing home, like the wait time to emergency, let's go build more because they're waiting. actually is a good excuse for us to sit down as a system. Interlake, Selkirk Hospital is 50% full of alternate level of care. So in other words, people who don't need to be there waiting for nursing home. So of course I can't help it. And I'm saying, well, wait a minute, do they need nursing home or should they be home with home care? Like none of you in this room, if I ask you, can hardly wait to get to be in a nursing home. None of you. And none of you want your parents in a nursing home. And so when I asked Selkirk, how many of these people could go home? And they said, well, probably all but 2, but we don't have enough home care. And then the ones who really needed nursing home, how many actually wanted to be in Winnipeg because their family was here? Well, that's Winnipeg. They say, well, wait a minute, we're a system. So instead of them sitting in Selkirk, why wouldn't we give them a bed in Winnipeg, which is where they want to be anyway? And guess what the real question was? Health Science Center hopping mad. We can't repatriate patients. Patients shouldn't be here. They need to go home. They need to go to Interlake. It's all Interlake's fault. So we've been in this system of blame, blame, blame. So going back to your question about emergency rooms, it's no different than Health Science Center. Beds are blocked because we can't get them to Interlake. Interlake's saying, well, half of our patients. So this is just an issue that I've just dealt with within the last month. And I'm thinking, wow, this really, it's exactly what your statement was, that when you see a number, ask the questions. Ask the question. Very good, very insightful. I'm chewing up your time here.
Online, we have a question about the cultural education. You said training on correcting cultural education online. So if you send me that information, we'll send it out as the email blast to everybody.
Okay, so the actual terminology from BC is the cultural safety training. So they use for training. You can also Google this because they've got a great website. It's called SANYAS. SAN''YAS. Each of the regions has, except for Northern, I believe, has actually purchased spots so that the regions have been supporting staff to take it. They say it takes about 8 hours, but I tend to like to read everything, so it took me way longer. But I feel free. And
I just want to say that Jen and myself have done the
good. How did you find it?
It's extremely informative.
But they underestimated.
Well, that's what I said, just because I read everything. Okay.
Well, I did some at home because I was feeling about it at 5. It was full.
But they were very selective about people taking it. Because according to what I heard is that it's very expensive.
The course is...
Which that's the one that I emailed you, that I ended up taking.
So the course isn't that expensive, $250.
Oh.
$250 because we have paid provincially for all the work in the background, and we purchase seats by bulk because behind each one of those trainings is actually a live person, as you know, that facilitates. So I think it's going to be up to each RHA, and but it's something that I think is.
And you also have to interact with it. So it's not as if you can just read it. They want your participation. You
Yep.
have to watch the next module until you do, which is good because it shows that you
Tricia?
So I just wanted to make a comment that as a college, because of this whole truth and reconciliation and all of this stuff, we are looking at possibly creating a shortened version of a module to give all of the practitioners in our field at least something. And it would probably be something that would be worked on with the Alliance so that it would, be available for all professions. I do believe it should be embedded in educational programs at the beginning, but there's a lot of us out here practicing without anything.
So we do also work with the university, who has also purchased seats. I'm delighted to hear you talk about the Alliance. So my own college is also looking at this. We've got some students looking at options. So perfect.
Well, start somewhere.